Thank you. Good afternoon, everyone. My name is Arthur. I practice intensive care medicine. As a disclaimer, my boss, Dr. Erasmus, was supposed to give this talk, but then he didn't think he would be here, so he threw me under the bus. I'm happy to be here, and I'm going to keep most of my talk around the area of sepsis. And I practice between here and the high-income country ICU, and it was a very difficult conversation to bring the things that we do that side and fuse them with here. So I decided to stay within context. My passion is about frugal innovations for intensive care medicine, acute care in this setting where we don't have many ICUs. So everything around my PhD work revolves around actually outside the ICU to do everything possible to prevent you getting to the ICU. The two cases that have been presented really highlight the challenges we have in the system. I was told I had to declare some conflicts of interest. I'm a bit busy. One of the things is I sit on the Surviving Sepsis Campaign Task Force and a bunch of other things, but none of them has any conflict with this presentation. So, Erasmus tells me and so I called Keith and asked, are you sure? And they're like, yes, you have 15 minutes. Typically, just a talk on CRT alone is 2 hours. But we'll try, between Erasmus and I, we'll try and deliver something useful. So a lot of the things have been mentioned. And interestingly, a lot of the therapies we conduct in the intensive care unit for acute kidney injury can actually be done outside the ICU. My talk is, I'm really going to try and focus on making sure that patients such as the two that we lost are actually managed better. So very quickly, I'm going to keep it around sepsis. There's one recurring theme I seem to get, and it's not just in Uganda, it's in other countries, that people tend to separate malaria and sepsis. Malaria causes sepsis. We have to always go back to the basic, that sepsis is when your body responds to any infectious process. Is malaria not an infection? Exactly. So HIV can cause sepsis. Any infection, it can cause an insult. So these criteria have evolved over the years, and one of the problems we're having on the task force in the meetings is some of the disagreements and the scanty data that is coming from Africa. Because as we now know, sepsis has different phenotypes. We have now identified 4 different phenotypes. So not every patient will respond to fluid, not every patient will respond to CRT, not every patient, and so on and so forth. So we're getting a lot more into personalized medicine. So why is sepsis on the rise? One, the NRM government will tell you that life expectancy has increased. The other thing is, with increased life expectancy and better economy, steady progress, we now drive cars, we now do more high-risk activities, take more alcohol, and NCDs are coming. Hospitals, training more doctors, and they're going poking patients, with all manner of procedures. And then, of course, we are soon having a kidney transplant unit here, and so, of course, the risk of more immunosuppressed individuals to add to the HIV population be there. So, not every good thing is good. So, I also try to focus a lot on, I'm trying to see what the problems we have here. This has been alluded to in this paper we published a long time ago. And again, this is a typical patient. No access to ICU, I think that was the second patient. Yes, and very many patients do not access ICUs. We did this study, and Robert has alluded to it. He was a senior author on this paper. At one time, I ran the intensive care unit at IHK with my boss Erasmus and other colleagues. And one of the challenges we noticed, as you can see from the etiological diagnosis, sepsis came first. Now, this was retrospective, so these are diagnoses that are picked out of the admission charts. That's why you see again malaria featured quite prominently. We see now in malaria, non-endemic, people who come from malaria non-endemic places, so Chinese, Caucasians, when they get malaria, almost always they get AKI requiring dialysis. I think we had, in 1 year, we had about 27 Chinese patients who would come in malaria and then they would need dialysis. And they tended to do well with IHD. Of course, we lost some. So the other challenge was, in all these patients that required IHD, we were trying to demonstrate that if you can don't give up on these patients. If you can do intermittent hemodialysis, you can save them. But all of them needed vasopressors. So, understanding, Dr. Robert has alluded to patients who are at risk of clinical AKI. And if you look at this conceptual, what we call a conceptual framework, with sepsis, the key word in everything up at the top is early. And that's the thing. The most important takeaway today, early recognition and a high index of suspicion. That's all. So he talked about biomarkers, and this is just basically the clinical pathway. I'll share this slide with the postgraduates, and in trying to understand what the pathway to and how the role of biomarkers. Now, in the high-income place that we are, we do NGAL, we do these things, and we are able to pick these patients at risk very early while they are still on the ward. And then the nephrologists pick them up and give them targeted care. Then there has been a challenge with again, when we talk about phenotypes, there is a subgroup of patients who will have AKI, but urine output will be normal, and the biomarkers will not be there. Now, this is what Robert was alluding to. Creatinine and urine output are useful. However, they give us differential risks. So it means that, what I'm saying is that all of us have our baseline normal creatinine. But when we fall sick and you start having injury, then it's very difficult to talk about baselines. So creatinine is only useful as a trend to us in the ICU. This has been talked about. There are the various rifle, Acute, and KIDCO. And then, of course, the clinical criteria and staging for acute kidney injury. There's one thing that I want to talk about. One thing that we actually now do is what we call the urinalysis score. It's, well, it was started by nephrologists who do critical care. As you know, sometimes you can do two pathways in medicine. So I wanted to bring this here because I think it's something that's easy to do. There is data that shows that, especially in sepsis patients, more renal epithelial cells were able to predict AKI. So this is one take home. Then the other thing is renal angina index. This is a score that was done by the Japanese, and it is something that we are now adopting in the intensive care community globally. So you will notice I'm talking about identification, because these are things you can do very early. So postgraduates help you. So the only way that when you get AKI, and if you're lucky and you make it to the ICU, you might not get dialysis. Now, we published this paper about 8 years ago, and we're just talking about sepsis management. Sepsis kills. Sepsis is a very, very serious condition. It kills, and we are still trying to figure ourselves out. Again, early diagnosis will help you reduce mortality. So, identification, have a high index of suspicion for a patient with sepsis, try to identify what the cause of sepsis is, treat it early, and treat it appropriately. Obviously, I know we have challenges with antibiotic resistance. Where possible, in your hospital, wherever you are, develop an antibiogram, because that is the only thing that's going to help you. So I know that there is the antimicrobial society, whatever it is. That's a very, very good way to go. Because once you lose that window and you then get established sepsis, it becomes very, very difficult to treat you. There's a study that was published that showed that with every 1 hour delay in initiation of appropriate antimicrobial therapy, you had a 40% increment in progression to acute kidney injury. And I'll keep reiterating the fact that you have to do these things early. So, fluids. We have now 4 phenotypes of patients, their response to fluids. But it's very important to understand the pathophysiology. Sepsis, in itself, creates some really, really serious capillary leak. Now, so if a patient comes and is hypotensive, right now I think the sepsis task force, we are arguing about the 30 mils per kg, right? That you're supposed to give within the first 3 hours. The reason is that you leak a lot, okay? When you leak a lot, you end up causing renal congestion. When you cause renal congestion, what happens? You impair renal perfusion. When you impair renal perfusion, what happens? You worsen the progression to the injury, or you now kick the patient further along the way to failure, and then you're in trouble. So, the question is, what do we do? There are studies that have come out. We looked at, there was a study done in Andromeda. What will you use to guide your therapy? First thing is, easiest thing is capillary fill. In the high-income country, we can do passive leg raising, like you said, but that's because we have a cardiac output monitor on you. Okay? We don't have that here. In the new ICU, we'll have the monitors. We'll be able to do that. But do we have the human resource to do the passive leg raise? It's a very difficult thing. So let's try and keep things simple. You have arterial pressure, you have urine output. That's, I agree, it is the 6th vital sign. And then you have capillary fill. Please take that seriously. Now, this basically highlights fluid therapy in septic, AKI, and the potential harm pathways. Okay? And this has to do with phenotypes. Now we are doing transcriptomic studies that show that different people respond differently to therapy. And the sub part of our work that we are doing here, next year, we shall identify Ugandans with different responses to acute respiratory failure and as well as sepsis. Okay. Now, in the Surviving Sepsis Campaign Guide, one of the things, as doctors, as you go out there, your number one, the majority of your patients will be the pregnant woman. We can't rule that patient out. The guidelines are not validated in this population. So the goal of therapy, now talk about fluid therapy, is to restore adequate tissue perfusion. Use MAP targets, I've talked, use urine output, capillary fill time. If you have lactate, that's your target. If you have a central line and blood gases, because in ICU what we do is just get a gas, and we measure that, and that will be our target, and lactate, and we'll work along with that. Be very careful when you're giving fluids. A lot of studies have now come out showing that conservative patients who get conservative fluid strategies get less AKI than patients who we just throw fluids at. And then, of course, noradrenaline versus dopamine. Although now it's now norepi, if you don't have norepi, use adrenaline. What we are noticing now, and that's just anecdotally from our practice, we are about to conduct a study, is that if you come in and your capillary fill is tricky, I give you half a liter of Ringer's lactate, and then the next fluid, and then check your capillary fill, then the next fluid will just pop in a little adrenaline. Because too much fluid, again, in a setting where we can't ventilate you, to push, because you get pulmonary edema, and then you can't ventilate you, you're going to drown in your own fluid. The Zambians did a study where they randomized patients with sepsis to 30 mils per kg and another, just a standard of care study. And the patients who got more fluid died. We did a study here in Malawi. We're just looking at respiratory failure patients. 77% mortality. One thing that we noticed was that, the relative, patients were on average getting, in the first day, 4 liters of fluid. You come with respiratory failure, you get 4 liters of fluid. What do you think is going to happen? Then we go to, they say, oh, respiratory failure, they call Dr. Rodria, they miss a pulmonary, and then he comes back the following day and the SHO is signing a health certificate. So I want us to think philosophically about frugal. Now, special populations. The pregnant woman, maternal physiology is totally different. So we don't even know if capillary refill works in that population. Okay? So this is, I'm just making you think. We did a study in HIV patients in IHK, and we noticed mortality was twice as much. But more importantly, they have very, very profound septic shock. And I had this conversation. We were supposed to do a trial with Dr. Sally, but we failed to get the grant. And we're just going to prepare fluids for resuscitation in HIV patients with sepsis and see. It seems like their capillary leak is so bad that any amount of fluid you give them doesn't work. So these patients are more likely. Please think about pressing them earlier. And this might actually apply to the whole population. Respiratory support. So in ICU, we intubate you, of course. The only problem is, if you get ARDS, it's very likely to worsen. This might be the first time you're hearing about renal pulmonary syndrome. The mechanism is not understood. But in patients who have ARDS, we also notice they tend to get requirement for renal replacement. And then the rest of the ICU-related things are here. I'm running out of time. Now, before I close, timing with CRT, maybe Erasmus will help. We got, in 2014, we managed to convince the management, some of you are there, of IHK to buy a CRT machine, because we were losing patients with septic shock. Went to Germany, was there for a month, trained, worked in a nice hospital, and where they had 65 dialysis CRT things, came back, and the first 9 patients in whom we did this all died. So, first of all, the teething problems. Secondly, the patients with AKI, we did not know when to start, because the things that I was taught by my German professor, I applied them. Nothing. So over time, we started to learn that every patient is different, and that delaying, we moved our targets to 0.3 instead of less than 0.5, and then we started to save these patients. So I hope Dr. Pate will talk about CRT. Okay. You won't talk about it? You're talking about it? Good. So all these studies showed no difference, whether early versus delayed. And I think Dan will just tell us. So in summary, index of suspicion, be very high. For early initiation, not superior to delay. And if you delay, actually almost 40% of patients end up not needing CRT. And then of course, doses he'll talk about. So he talked about the pathways outcomes, about the outcomes of patients that that is something I've already seen. So future research, as I'm a researcher, I like to ask questions. What's the best fluid? Erasmus and the other intensivists, we have our MESAU where we argue these things out. What's the best way to identify AKI at its earliest, especially in this setting? You guys will need to think about our context. There's a lot of mistakes being made in the West, and they're very expensive things, which we don't have to do. We can do our things better, more frugally, and more cost effectively. And these are the rest of the questions that we can ask. Thank you very much.